10 lessons after all the TAVRs I've done in the last 15 years. And this is the first TAVR that we did November 26, 2007. It was like magic, right? Everything worked. It was beautiful. And since then, the number of TAVRs that we've done every year has actually gone up, and in fact, we are almost nearing or maybe north of 6,000 TAVRs at our institution. So the first lesson that I have learned about this TAVR is that TAVR is actually a team sport. And everybody, it takes a village literally to do a TAVR and to build a TAVR program. And I think everybody is an equal stakeholder. So this is not a one person, this is actually truly, you have to respect all the stakeholders, whether it is imaging, surgeons, your fellows, nurse practitioners, all of them. I think the most important thing that I learned very early on was that good imaging is key to successful TAVR. And I think the most important thing is accurate device sizing. And you will not believe this. This is pre-CT era, 2010. So this is how we used to size, right? Look at the CT, it's 20.9 on TEE, so we use a 23 millimeter valve. There is PV leak, moderate. But when you look at later on, we dug out the CTs in these patients because we had acquired these CTs and we were able to go back and do the analysis. Look at the maximum dimension, it was 28. So no wonder there was PV leak with a 23 millimeter valve, and it became very clear that the annuli had huge variations in shape and they actually changed in systole and diastole. And here is another case example that we did in 2010. And if you look at it, in one of the measurements, the measurement was 21.6. But look at the cross-sectional measurement. This is all retrospective analysis because we were using CT only for vascular access at that time. And it became very clear that even a 29 millimeter valve would have actually had PV leak, not just a 26. And there was no 29 millimeter valve at that time. So one of my associates actually did this analysis. We went back and looked at CTs in these patients, and our analysis was actually one of the first analyses to show that CT sizing was the better way to go rather than by doing echo. Now, this is just a case. This is something that we did in 2008, and look at this aortic root injury. And when we went back and looked at the CT, it became very clear to us that the minimum dimension here was 14.6. There was MAC, there was contiguous calcium in the LVOT, and if you look at the area, it was only 241, right? With a valve size of 23, it for sure caused injury. The second lesson I learned was data is powerful, right? I think we all know about it, but nonetheless, it just highlighted how these clinical trials were done in TAVI, so there was no shortage of patients. All right, patients were actually lining up to get these procedures done. So I think multiple successful devices in multiple trials was the key in convincing, and all of these trials published in the New England Journal of Medicine, the Lancet, and JAMA, all of these things were actually very, very important in driving the field forward, changing the guidelines, allowing for proper reimbursement. Very early on, I learned that what may seem outrageous may actually not be that unreasonable, and that age is no a barrier to TAVR. So this is a 100-year-old patient in 2011, had a proximal right, had a left main trifurcation. We stented the right, stented the left main, then actually did a TAVR in this patient. You can see this is the old valve, all right, and in fact ended up with a good result, no gradient. The valve function looked excellent, and the tall gentleman is the guy. He was actually a week later in my office, after his TAVR procedure. And if you look at him, he actually continued to do better. And this is when he was 104. I got an email from his daughter that he was actually doing well, and he actually lived to be 106. So unless we had pushed limits, we would have not known where the limits are, and this technology actually allowed us to do that. The next lesson that I learned was use all available talent to help your patient. Set your ego aside. And here is a patient, 75-year-old. Okay, look at the LVOT calcium. And, it all looked good. A little bit later, we saw there was actually pericardial tamponade. We aspirated, put the blood back through the vein, and then actually did picture on aortic root angio. Nothing really lit up. But then we actually did a selective injection into the cusp, and you can see that there is extravasation, there is contained or not so contained aortic root rupture. We worked with our neuroradiologists actually, and we coiled this, and this patient actually did just fine. Was discharged a few days later, and we avoided a sternotomy. So this is, applying all the lessons and everybody's skills to the task. And this is a patient later on, and this patient went home, and this is something that we published. And in fact, I get texts from people. Actually, the last text was from here in India a few months earlier, actually suggesting that they did something like this and actually saved their patient. What else did I learn? I learned that every crisis can be an opportunity. And very early on, I was a principal investigator of this Portico ID study, and we had to halt the study because there was reduced leaflet motion. We were doing 4D CTs naively, and we saw that these leaflets were not moving. Our trial was actually stopped. But nonetheless, what we did was we undertook a very thoughtful investigation of this, working with the engineers. We generated a New England Journal of Medicine paper, a Lancet paper, and started a whole field of subclinical leaflet thrombosis. And actually we found out that this was not just related to one valve, but all bioprosthetic valves, including surgical valves. I think, and this is something that we all know. So another lesson is, do not give up too soon on a crashing patient in the cath lab. And here is a lady, she's 99 years old. There's a tight left main, as you can see, subtotal. We put the Amplatz catheter across the valve, knowing that she may become unstable and we may have to do TAVR quickly. And we started doing the PCI, and she actually immediately arrested. She needed CPR. During CPR, no rapid pacing required. We actually then deployed the valve. This is the SAPIEN valve being deployed. And then, of course, we went ahead, put the Impella, stabilized her, crossed the lesion again, and did a nice bifurcation stenting. She was in the ICU for 4 days, and she actually was discharged a week later. And this is a few days after that. She actually turned 100. And then she lived to be 103. She was actually a Holocaust survivor. Be prepared for the worst. Here's a patient, 79 years old. This is a patient who's got severe aortic regurgitation presenting as angina. Okay, the valve that she has, the surgical bioprosthetic valve that she has, is a 23 millimeter St. Jude Toronto bioprosthetic valve. And if you look at this is 12, 13 years ago. All right, and if you look at the coronaries, they're actually very low. The quarters in the sinuses are very, very tight. There was no concept at that time of left main protection. We actually tried it. We said, okay, let's be ready here. And a guide catheter, you can see that the stent is actually in position. We deploy this valve. This is the earliest version of the SAPIEN valve, and it looked okay. So the LV this is pre-TAVR, and then shortly thereafter you can see what has happened to the LV. It's not moving much. You take a look at the picture. Of course, the left main ostium has been pinched. Good for us because we were able to pull this valve, stent back and actually deploy it. And one wasn't enough. In fact, we had to reinforce it with another stent as well, and actually then did intravascular ultrasound and all those things at that time. You can see what has happened to the hemodynamics, normalized, and this is actually the ejection fraction 1 day post. So I think we were prepared to actually take care of this patient. I think, what is the other thing that I learned? Learn from your mistakes, and some can never be repeated, such as this one. So this is, once again, this is the old SAPIEN valve. This was a MitraFlow valve. We protected the left main, and we are deploying this. But shortly thereafter, the patient, in fact, decompensated. This is what happened. We couldn't have occluded the left main. We injected, we had protected the left main. But what had happened was, this is basically at a cardiac standstill. Immediately we went on heart-lung machine. The problem here was the old SAPIEN valve, you didn't know which way unless you just, there was no way to verify. And that is exactly what had happened. So we very quickly put another valve now, this time in the right direction. And this is post second valve, all right? So the patient was extubated, decannulated in the cath lab and did well. Not only that, this patient lived 6 years later, now you can see this patient has mitral regurgitation. Now we've used a dedicated mitral regurgitation device actually to treat this. So another example of what happened. So here, remember your previous experiences and be open to new ideas. And here is a patient with pure aortic regurgitation from healed endocarditis, not a surgical candidate. And we tried doing a balloon expandable valve here. We thought we had it good, and then we decided to post-dilate, and then the valve embolized, as you can see here. And essentially what we did was, we pulled this balloon back, then went ahead, put another valve. As you can see, this time we actually oversized it a little bit more, so the valve anchored, and then we took a evolute valve because the other valve was actually sort of bobbing. So what we did was we cut out the leaflets of the evolute valve and anchored that valve there, and this patient was actually able to go home and actually did well. Teamwork and collective thinking, and the best ideas at times come from your junior-most colleagues and your fellows. And here is a patient, who's got a evolute valve. You would think they never fail, but here is one. And it is hard to cross these valves because the leaflets are actually a little bit tall. And we couldn't. So in fact, in this case, what we did was we did a transeptal puncture. We crossed the valve antegratally, created a loop, snared it out from the femoral artery, and then in fact created a rail and then crossed the valve and did this in a retrograde fashion. So, and I think, you will be humbled. And, I do live cases all the time, and here is one such live case we did. We were asked to show a very tough bicuspid aortic stenosis, look at the amount of calcium, and this patient we thought did great, but later on, actually after going to the ICU, in fact this patient decompensated, had aortic root hematoma, and ultimately didn't make it. So I didn't want to just show you all my successes, or our successes rather, and I think that aortic root injury is an issue when you deal with some of these very, very heavily calcified valves. Heart-lung machine saves lives. I think we've all evolving to the minimalistic thing, but I think occasionally when you do a lot of TAVRs, you will have a case where you are thankful that you had a heart-lung machine somewhere in the vicinity. And here is a case that we did many, many years ago. All right, and this is a patient that we had enrolled in the one of the evolute pivotal studies, and not a whole lot of calcium. We deployed the valve. Early on, you can see flow in the left main. Later on, we didn't see much flow in the left main, and there is a standstill. Immediately, we went on a heart-lung machine. You can see there is actually no flow. We yanked out this valve, all right, snared it out, restored the flow. Then we actually used a smaller valve. And then actually went through that, went into the left main ostium, ballooned it, and then actually stented it. Believe it or not, she actually is still alive and actually doing all right. So I think the important thing is, yes, we need to push the technical limits, but I think it's important to collect and publish data, and bicuspid is just one such example. So I think the only reason we can push limits is because we have data now to back us. So I think which is data that we have generated in bicuspids showing that the outcomes may actually be good. Being thoughtful and actually deciding what to do and what bicuspids not to do. The same thing with aortic regurgitation. We are doing it, but we are actually accumulating data. I think it's not about doing it willy-nilly, but actually learning from what we actually do. I think I've learned that some cases are more than procedures. They're actually spiritual experience. And here is a 49-year-old lady who came. She bought one-way ticket from Central Coast, California. She's got severe MAC. She's also got aortic regurgitation. This is one of the earliest cases of sapien in MAC in the world. We had no idea about neo-LVOT and all of those things. We got just lucky that this valve anchored and actually did well, and then we brought this patient a year later to actually do the aortic valve, which was done as a live case. So this patient has off-label use of balloon expandable valve and off-label use of the self-expanding valve. I think this whole field of TAVR was inspiring, right? To be inspired by these pioneers like Henning Anderson and Alan Cribier. I think what really mattered in America was strong leadership and properly navigating. So TAVR did not meet the fate of carotid stenting, all right? It is properly reimbursed, and this was by getting all the stakeholders. And I think I've learned you cannot miss out on game-changing innovations. And on that note, I will end by showing this case. This is a 78-year-old patient who actually had bypass surgery, but they forgot to fix the aortic valve and forgot to address the mitral valve. So this is a few months later, we in fact brought this patient, did a balloon expandable in the aortic position. Then we used a dedicated device called the EOS device for the mitral valve. All right, this is done transeptally. So this is the aortic valve, this is the mitral valve, all done during one procedure in a matter of about an hour and a half. So I think this is one month follow-up on this patient, and he's doing great. So let me just end my talk. And I mentioned earlier about my fellows. We are very fortunate to have 4 or 5 fellows, young people, and then also visiting fellows that come to us around the world, and they stimulate. And I think this is the young do not know enough to be prudent, and therefore they attempt the impossible and achieve it generation after generation. I'm lucky to hang out with these young people. And I have to say, this is the last slide here. So, the little younger guy sitting to the next old guy, he tells him, I didn't believe in reincarnation when I was your age either. So I think we should all have a very open mind. Thank you.
For your presentations. On behalf of Mr. Giakas, Dr. Tsigaresis and Mr. Iakovou, I would like to thank you for your presentation.